So I'd like to introduce to you Ms. Geneva Foster. Geneva is a Meaningful Use Specialist on SUMA Physicians Incorporated. She also is a board member of the Northern Ohio Health Information Management System Society. And she is going to present today on Provider-Driven Meaningful Use of CEHRT, and she will tell you what that means. Geneva, I'm going to turn it on to you.
Okay, thank you. So this presentation, the intended audience, and I know that there are students on the line that are hoping to get into health IT and specifically work with providers on meaningful use and the use of certified electronic health records. So this presentation focuses on those eligible professionals in ambulatory practices that have adopted and implemented or upgraded to 2014 certified electronic medical record technology, which the abbreviation is CEHRT, S-E-H-R-T. And the objective is to just share with the audience my observation as a meaningful use specialist on those providers who see more success in participating in the meaningful use program for this CMS. What I've observed is determining meaningful success: resistance, reluctance, and resolve. The first is resistance. For sound reasons or not so sound reasons, providers are resisting using certified electronic health records in a meaningful way. And for the not so sound reasons, it becomes a fulfilling prophecy for failure. So they either never implement a certified electronic health record, or when they implement, they fail to use it in a meaningful way to what the CMS is requiring. The group of providers that I've observed are those who are reluctant. They are taking kind of a wait and see, you know, this whole thing might get repealed, or what are the other providers doing? I want to see if they struggle with this, or if they have some best practices that they can offer me, or, okay, well, I'll go along with the program. Just tell me what is the minimum I need to do. And when they're striving for the minimum and they don't reach it, obviously, again, there's a great deal of failure in achieving meaningful use. The third group, and that's the group I'm going to focus on, is the group who find the meaningful use of electronic health records the resolution to some of the needs that they see for themselves and their patients. They are early adopters. Many of them have been using electronic medical records, EMRs, years prior to the CMS program. They use their EMRs for the stated reasons that the CMS wants providers to use EMRs: for patient safety and to apply research to outcomes, better outcomes for their patients, and then to find financial best practices. So what's affordable care for the patient and what also, you know, keeps the lights on at the practice. So now that we are in 2014, the EHR program is entering its second stage and its fourth year. So eligible professionals across the country find themselves looking at different criteria depending on when they first started using the technology and different reporting periods. So I'm going to briefly go over that before I get into how our resolved practitioners are addressing their own meaningful use of the technology. So for 2014, All eligible providers, the hospitals, the critical access hospitals, the individual healthcare professionals must adopt and implement or upgrade to 2014 certified electronic health records. That's regardless of what stage they're in. That's regardless of what year they're in. So it doesn't matter if they started in 2011 or they're starting just this year. They have to be on 2014 certified. I'm sorry? Oh, that wasn't a question? Okay. And then starting in 2014, all eligible providers must also report their CQMs, their clinical quality measures, electronically, apart from attestation to qualify for meaningful use. So I spoke about how there are providers in many years, like they're starting different year. They started 2011 or 2012 or 2013, or they're starting this year. So the ones that are starting this year are first-time meaningful users. They're pursuing stage 1 objectives and the 2014 electronic CQM requirements. So for them to avoid a Medicare payment adjustment in 2015, they have to attest for the first time by October 1. They also get to attest to a consecutive 90-day period of meaningful use that ends no later than September 30th. Again, CQMs must be submitted electronically, separate from the meaningful use attestation. The next group are the group that first attested to meaningful use in 2013. So they are still in stage 1 because every provider, regardless of what year they starts in stage 1 and has to attest to 2 years in that stage before moving on to stage 2. What's different for this group of stage 1, year 1, is that they have the 2014 electronic CQM requirements just like everybody else. Oh, and their reporting period for 2014 is one of the quarters of the year. So either they report starting January 1, April 1, July 1, or October 1. The next group is the group that first attested to meaningful use in 2011 or 2012 and has successfully attested to 2 years at stage 1. They're starting with stage 2 criteria. So for them to avoid a Medicare payment adjustment in 2016, they must attest to the whole entire, to one of the 4 calendar quarters, no later than February 28, 2015, and they also have the new electronic CQM requirements. So that's kind of the logistics. And so with all of that going on, you can see how daunting it could be, and providers can focus on, oh, okay, I got to do this, I have to have this reporting period, and I have all of these requirements to meet across all of these different objectives, and it's just so overwhelming. I just don't think I can do it. So what I'm finding is that those providers who have the resolve to drive meaningful use for their practice and their patient communities are not only achieving meaningful use, but they're far exceeding even the government's expectations for the objectives of meaningful use of electronic health records. So what I'm going to do is quickly go through those objectives for stage 1 and stage 2 in 2014 and give you a little idea of what is driving the providers rather than being driven by the Centers for Medicare Medicaid Services. So the first objective is computerized physician order entry, CPOE. In stage 1, eligible professionals must use the technology to order medications for more than 30% of their unique patients. In stage 2, which started January 1 of this year, it's 60%, more than 60% of unique patients' medication orders must be ordered through the EMR. In addition, more than 30% of the laboratory orders and more than 30% of the radiology orders. Our providers are doing all three well above the expectation because the meaning that they are deriving from this practice is that I know my orders will be clear when they go to the pharmacist, when they go to the pathologist, when they go to the radiologist, and when the patient is looking at them. I'm going to know what my medications are. I'm going to know what labs I'm supposed to be getting. I'm going to know why I'm getting this x-ray. And then it also allows any questions or concerns about the order to be identified immediately, often before the order is even sent out. And then the results are reported quickly because they interface right into the EMR. The next is drug interaction checks and clinical decision support. So in stage 1, these were two separate objectives: to enable the functionality of the EMR to let you know when a patient has a drug allergy or there's two drugs that interact badly, and then also to implement one additional clinical support rule. In stage 2, those are combined and they're increased. So the CMS wants to see providers implement 5 clinical decision support rules, as well as enabling the drug allergy. And for those providers that are go-getter, they're like, well, of course, this makes total sense. This is a tool that helps me and the care team support prevention and control of chronic conditions. And once verified, we are assured that we're going to catch any drug allergy interactions. So this one is a no-brainer for the providers who have resolved to use the technology in a meaningful way. E-prescribe in stage 1 required, well, there were 2 linked objectives. One was core for more than 40% of all permissible prescriptions. The EP would not only use the technology, but order them electronically. So not electronic fax, not printing a script from the technology, but actually electronically transmitting the order to the pharmacy. And then also to enable the functionality of at least one internal or external formulary. This is what lets the provider know if there's a generic medication that might cost the patient less money to fill that prescription. In stage 2, they're combined. You just have your formulary turned on, and you need to e-prescribe for more than 50% of your medications. And like I said, this is kind of a no-brainer for those go-getters. They're like, hey, all my patients receive the most appropriate and affordable medications, and I have the assurance that the orders are legible, and I can actually track them very easily. Patient demographics. It's the exact same patient demographic information for stage 1 and stage 2. It's just the number of unique patients that we collect this data for. In stage 1, it's more than 50. In stage 2, it's more than 80. Our practices get between 95 and 100% of this information because in particular, one of our practices is a patient-centered medical home that focuses on health disparities. And so having this information along with other information allows these providers to do research and gain insight into the factors, whether they be social, biological, or like medication therapy itself just doesn't work in treating chronic conditions by race, ethnicity, gender, and age. So now this is a big one because in stage 1, you can see it split out among 4 different objectives. One objective is to maintain an up-to-date problem list of diagnoses for more than 80% of patients, to maintain an up-to-date medication list for more than 80% of patients, to maintain an up-to-date medication allergy list, and then also when transitioning a patient into the care of another provider or setting of care, to provide that provider with a summary of care record for more than 50% of those transitions of care. In stage 2, the objectives are all combined, and what our providers are doing and reaching such a high level of compliance with this objective is they're focusing on continuity of care. I think that's the wrong word. But in any case, so what they want is to be assured that the next setting of care or provider of care has all the information necessary to continue the same quality of care that they've been providing the patient. It would, I think, literally break their heart that the patient, I've been coming to you for all of these years, I feel like we've had a great relationship and you're doing right by me, and then you transfer me over to somebody else and, you know, they just don't know what's been happening with me. And that takes the burden off of the patient, who may, depending on what the situation is, where they're going, may not even be able to recall or reiterate their care plan to this point in time. And it also improves opportunities for collaboration with other settings of care and providers of care. And so when I see my providers that are focused on those objectives from that point of view, they do very well getting the summary of care records with the problems, the medications, and the medication allergies over to the next provider of care. Vitals, again in stage 1, they're very similar to stage 2. It's just the difference in threshold. So in stage 1, we want to see more than 50% of our unique patients have their vitals recorded as structured data. In stage 2, we want to see more than 80%. Again, this is one that our providers are between 90 and 100% because they're driven by the desire to assure that their medication dosing is appropriate. They want the ability to address weight concerns, both abnormal weight loss and weight gain as soon as possible, and to address cardiovascular concerns that might lead to stroke or heart attack as soon as possible as well. Smoking status, again, this is a no-brainer. In stage 1, it was more than 50% of patients over 13. We have a recording of what their smoking status is. In stage 2, more than 80%, and what's driving our providers is they want to be able to get in there and provide cessation intervention for as many patients as possible, because smoking is one of the biggest health risks. Clinical quality measures and electronic clinical quality measures. In stage 1, our providers had a set of clinical quality measures of which they had to report on 6 total. In stage 2, the clinical quality measures have broadened. Providers need to report on a total of 9 across 3 national quality domains. but what's driving our providers to do this and get this in, and I mentioned this before, starting in 2014, those clinical quality measure reports have to be submitted electronically. What's driving our providers is that they use that information themselves within their own practice across our medical practice for research. So they have a desire to know what the factors are for best patient outcome, what works, what doesn't work, and for whom. Oh, I'm sorry. Electronic copies of health information. So in stage 1, the CMS wanted more than 50% of all patients who are seen by the EP and requested an electronic copy of their health information, get that within 3 business days of their visit. In stage 2, we want the same, but additionally, of that more than 50%, we want to see 5% actually use that information and either transmit it to a third party, or, and we'll see later on, use it to communicate with the provider. So what's driving our providers, because this is something slightly new for our providers, and so what's driving them to work out the details of how we're going to get this done is the desire for patients to truly see themselves as a central member of their care team, and also getting this information to them helps patients remember their care plan and take active roles in it and direct their health information to third parties as the patient sees fit. Clinical visit summaries. In stage 1, we wanted patients to more than 50% of visits to result in a clinical visit summary to the patient within 3 business days. In stage 2, it's still more than 50% of office visits, patients are provided their clinical visit summary, but it's within 1 day. And again, this is another thing that helps the patient remember information discussed and provided during their visit, including but not limited to their medications, allergies, and preventative care plan and follow-up appointments. Protecting eHealth information. This is huge, 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 and I just have a brief 2-liners for what drives our providers: their reputation and the trust and confidence that their patients have in them. People are dealing with some very stigmatizing conditions, and we wouldn't want that information to be outside of the privacy and security of our practices. It's just another thing that people get anxious about, and so to not have that worry, it does help with their treatment. Clinical lab test results. In stage 1, we want to see more than 40% of all clinical lab results that have a positive or negative or numerical information structured into the EMR. And in stage 2, we want the same thing, but just for more than 55%. In stage 1, it was a menu option, so the provider could choose to do it, but in stage 2, it's core, so they have to do it to be a meaningful user, and they have to do it at 15% more of the time than in stage 1. So what has gotten our providers to nearly 100% on this is thinking about the patient, thinking about the treatment plan. Different results send the care team in a different direction. So this lessens the time the care team waits for these results and discuss the implications of the results. And for some conditions, you know, the patient sitting around waiting for these results, they're waiting anxiously, and that's another issue. And so the sooner we get the results in, the sooner they're structured into the patient's health history and EMR, the sooner the patient can move on with the rest of the care team of what we're going to do next. List of patients by specific conditions. This was one that, you know, like I said, those providers are like, I'm resisting this, or I'm reluctant, I don't get it, I don't understand. For those go-getters who have resolved to do this, they're like, yes, because they're already doing research, because they have a desire to reveal health disparities and gain understanding of therapy-specific factors, impact on prevention and treatment of chronic conditions. So being able to have all this wealth of information and be able to run a report by a specific condition. So I'm a cardiologist and I want to run a report on a specific condition that is impacting a large majority of my patients. Or like I said, our patient-centered medical home that is focused on health disparities might want to see, well, what is the difference in outcomes between African Americans and Caucasians, or women and men, or children and adults. So we can run a report for diabetes, obesity, heart disease, and then we can start drilling down into the data. Reminders for preventative care, stage 1, we wanted to see more than 20% of unique patients over the age of 65 or under the age of 5 get reminders for appointments. In stage 2, we want to look at the whole patient community and see that more than 10% of the patient community gets reminders for preventative follow-up care. Our providers are getting this done because for them it improves the communication with their patients. They've been doing it anyway. Now they're just getting acknowledgement through the EMR, and especially they want to see that communication with their patients who have risk for specific conditions that may be prevented, and then also for chronic conditions that may be improved and well controlled if they continue with their follow-up treatment. Patient-specific education in stage 1, this was an option that providers could choose to provide more than 10% of their patients with patient-specific education. In stage 2, it's a requirement. It's still more than 10% of unique patients get this patient-specific education, but providers must do it now. Our providers have been doing it well above that 10% threshold because for them it gives the patients a foundational set of information about their health, their fitness, and their medical concerns. And it's a catalyst for continuing that discussion with the care team. And more importantly, when you're away from the office, when you're out in your daily life, what do your families and friends understand about your health concerns? And this is a great way to get that conversation going with the support network that you have outside of your care team. Electronic submission of data to immunization registry. In stage 1, this was an option, and it was just a test to see if your EMR actually had the capability to send immunization data to your state registry. Stage 2, it's a core objective to continually submit immunization data electronically. And for our providers, there's a couple of things going on. One, because we're a large medical group practice, we can do this as an organization. So the technical folks can help them get this information submitted, but they feel that they must do their part to support public health within our communities, as well as supporting preventative care for patients. So if we know, our patients are due for an immunization for the flu, and flu season's coming up, we can really get our flu clinics going and get all of our patients that really are at risk if they get the flu immunized. Secure electronic messaging. So now we're seeing some of the new objectives that are coming into play, and I discussed this a little earlier in the providing electronic copies of health information to patients. In stage 1, this secure messaging was not an objective. In stage 2, it is, and it's a required objective. And for our providers, even though they're still trying to wrap their brains around how is it that we're going to get our patients to actually participate in this, their focus is on the desire for patients to truly see themselves as the central member of their own care team. And then it also improves communication with patients, again, especially those who may be at risk for specific conditions or have chronic conditions that may be improved or well controlled if they stick with their care plan. Electronic transmission of syndromic surveillance data. In both stage 1 and stage 2, these were menu options, so the provider could choose to do it. In stage 1, it was a test to see if your technology was able to transmit that syndromic surveillance data. The problem across the country was most boards of health, state boards of health, did not have the capacity to receive this data electronically. But as we move forward into the electronic health records incentive program, they've had to figure it out. And so now many of them can receive this electronic data. So in stage 2, for those who are going to go for it, it's still a menu objective, so you can still choose to do this one, but the CMS wants to see successful ongoing submission of this data. For our providers who are going for it, it's, again, to support what they feel is their obligation of public health safety within our communities right here in Northeast Ohio, and also, again, supporting preventative care for their own patients. Electronic progress notes, this is a new one, which had us scratching our heads because our providers have always been driven to keep their progress notes electronically, because the electronic progress note, when it's combined over time, it's like a book. And so our providers can go into that book and flip the page back to a specific time in the patient's care story for a reminder or some insight into what's been going on with the patient. It was not an objective of stage 1. It is an objective of stage 2 to enter at least one electronic progress note in the EMR for more than 30% of unique patients. Imaging results, this is also brand new, and it is a menu set objective, and similar to lab results, what we're looking at is either having a link to the imaging results from radiology in the EMR, or the actual image in the EMR with the results. Again, our providers are driven to get this done in stage 2, even though it's an option at this point, because it lessens the time the care team waits to see and discuss the implication of diagnostic imaging results, and it lessens the time the patient is waiting anxiously for those results. Family health history as structured data. This was not an objective in stage 1. It's a menu objective in stage 2, so again, it's something that can be selected. And what the CMS wants to see is more than 20% of all unique patients seen by the EP have an entry for one or more first-degree relatives, or an indication that family health history has been reviewed. For our providers, this is a no-brainer. Provider wants as many pieces of the puzzle for preventative care and improvement and control of patients' chronic conditions. So if we know what's been going on in your family's health history, this can give us insight into what may happen for you or is going on with you right now. The next set of objectives are all new, and they're all menu set objectives, and they all have to do with public health. And so our providers across the board, if they can, they want to support these objectives for the public health and safety. So cancer case information submission. This is the objective to have successful ongoing submission of cancer case information to a cancer registry. And then the next one is specific case information. So you're not an oncologist and you don't do immunizations, but you do collect data on specific cases to your specialty. So the CMS wants to see successful ongoing submission of that data. And again, it's to support public health as it relates to specific cases other than syndromic surveillance and cancer cases within the community. Okay. That's my presentation. That's what's driving our providers to get at the CMS's objectives for meaningful use. And they are doing gangbusters. They're going above and beyond what the CMS is looking for. And so I'm open to discussion on what you think about that.
Okay, Geneva, this is Chris.
Yes.
One of the questions I have, let me get my microphone here. One of the questions I have is, in comparison to other providers, where do you providers rank? Are other providers as good as your providers are in meaningful use?
Well, of course, I want to say that our providers are top notch, but we have. So for the audience, to let you know a little bit more about Summa Physician Inc., it's the large medical group practice employed by Summa Health System. And so we have approximately 400 eligible professionals for the EHR incentive program, and they're across the board. So the ones that I have discussed in this presentation, I would hold them up to the whole world and say, this is how you do it. But we do have those who are resistant, and they're still not on the EMR today. And then we have those who are reluctant, so they're on the EMR, but it's hit or miss year to year whether they're going to achieve meaningful use. And I think that's what's going on across the nation.
Mm-hmm.
So I think we're on par. Say that again?
Have you had any physicians retire as a result of CEHRT and meaningful use?
I couldn't understand the question. You're kind of muffly. Could you
Oh, I'm
repeat it?
sorry. Have you had any physicians that have retired?
We have. We've had physicians that have retired. We have had physicians who have gone on to, who have transitioned to other practices. And I have one interesting story. And this wasn't a physician who was actually reluctant. He actually, okay, I'm going to do this. He did it. He achieved meaningful use. But there were some other, I guess, issues going on. And so he left, joined a practice outside of our medical group. But then within 6 months, that practice joined our group. So he was right back in the same situation that he thought he was going to leave. But we've had one provider, and it was just prior to me coming into this position, who was just like, I can't do it. It's time for me to hang up my hat. And we have one provider right now who keeps saying, yeah, I'm going to retire. I'm going to retire in June. I'm going to retire in December. But he's really an interesting character because he sees this as a challenge. And so he complains about it, but then he's like, no, I'm not going to let this drive me out of practice. I'm going to do it. And he's doing it. He's doing it. He's on the EMR. He got on the EMR at the end of last year, and he's doing it. So yeah, so very, very few have retired over this.
Mm-hmm. Because just in my work with the Regional Extension Center, one of the things you notice is we have physicians who literally would stand up on tables and say, we're not going to implement, we're not going to do this, you know, to hell with meaningful use. And when you look at it, it's really stuff they should have been doing all this time.
Mm-hmm. Well, and that's why those who were early adopters, I mean, I have about 60 providers in this whole entire group. They adopted the technology in 2011, and they were meaningful users and have continued to be meaningful users since 2011.
That's incredible.
And the interesting thing about them is some of them, you know, they were new to, you know, they're right out of their residency programs. It's first time. This is my first practice. So they're young, and they're like, yeah, technology, yeah, bring it on. And so they just went for it. And so they've never been on paper. They've, for their whole entire practice, have been on the certified electronic health record and been using it in meaningful ways and going above and beyond the numbers that the CMS is required.
Mm-hmm.
And then the others, yeah, sure, they were on paper, but they could see all of those benefits that I discussed to using the electronic medical record. They could see it, and so they're like, okay, we'll be the first. We'll go first.
Excellent. Excellent. Are there any other questions for Geneva? You can just hit the raise your hand button, or you can just jump in here.
Hi, Geneva. It's Becky Casper. I just
Hi,
wanted to ask, how are you? I just wanted to ask you a question about your role. Are you then working with that whole group of all 400 physicians?
Yes.
Okay. And then
so we have a team. So we have an entire team, and here's how our team breaks down. We have our clinical system analysts. They are the ones who are certified trainers of the EMR that we use, which at present is eClinicalWorks.
Okay.
And they are responsible for making sure that all of the end users, so it's not just the physicians, it's not just the clinicians, it's everybody in the practice knows how to use the EMR per their role in the practice. And then we have a small team of what we title EMR support technicians, and that was actually my first job 3 years ago in health IT, and that is like the assistant to the clinical system analyst. So
gotcha.
They go out to the practice, they follow especially the front office and the back office and make sure that the training sticks. And then when the training period is officially ended, they might come around for a few more days just to make people feel easy, like you're not too far away from me.
Right.
Then our next group is the support analyst. So these are the folks that get the calls, you know, I'm trying to do this and it's not working, or that, you know, I forgot my password, I got locked out of the system, whatever technical issues that they might be having with the system. And then I'm the meaningful use specialist. So I'm everything meaningful use. So once they're on, once they're trained, once they're using, I monitor. If I see struggles, if I see problems, I reach out and I say, what's going on? Let's do a workflow analysis, because it might be something that you're doing. Or if not, it might be a break in the system, and then I work with the vendor to find out where it's broken and how to fix it.
Gotcha. And then, of those physicians in your group that attested to meaningful use stage 1 already, 2011, I guess, are they? So, are you saying they're like already able to attest to stage 2, or where are they with that?
They are not able to attest to stage 2 quite yet, because the first requirement of stage 2 is that you adopt or implement 2014 certified EHR technology.
Gotcha.
And we adopted or we upgraded to the 2014 certified technology in March, mid-March, St. Patrick's Day, as a matter of fact. Okay. And for stage 2, well, actually, if we go back to the final rules for the EHR incentive program, after your first year of meaningful use, your reporting period is the entire 12-month calendar year. But in 2014, there's so much going on, and there's so many people participating in the EHR incentive program. If we waited until January 1, 2015 to attest to meaningful use, the system would break. And it broke this year. It broke this year. So we didn't have hardly as many people in the system as we anticipate for this year. So they have given a quarter for the reporting period. So since we didn't upgrade until mid-March, the first time those stage 2 providers can attest is July 1 for the quarter prior. Okay.
I was going to say, it makes your job probably a lot harder when you have people still in stage 1 and people who are looking for stage 2.
I'm just like, who's on first?
Yeah, it's great to have everybody at the same place, I'm sure.
Yep.
Thank you very much. I appreciate it.
Yeah, you're welcome.
Geneva Bradwood has a question.
Okay. Is it on? Is it in the?
No, she's going to ask it in person.
Go ahead. Go right ahead.
I just had a quick question. So we talk a lot about providers sort of resisting in general, and it's hard for me to tell really if they're resisting due to just the straight up fear of the change, due to the requirements being too much for them, or if they really just straight up disagree with the benefits of meaningful use. Recently I was in a conversation with one of them, and the way that they described meaningful use to another group of providers was that it was the government poking their nose into our records from 10% to now all of them, and that they were very indignant about the fact that we were sharing our records. And I thought that was a really interesting perspective on what meaningful use was, and something that wasn't really presented as in my classes before.
And that perspective is out there, and it's out there more than you would want to think. And like I said, it's part of So at the top I said, there's the 3R approach to meaningful use. That provider falls into the first R, resistance. And I don't know why. I don't know why providers have that feeling. And it's not a mandated program. And I have some resources up here on the screen for you. I contact the last resource all the time, the Electronic Health Records Information Center, and they have a disclaimer every time I call in. This is not a mandate. You can choose not to participate in it. The only problem is that if you charge Medicare, you are going to see some payment adjustments starting in 2015 if you don't participate. But if you don't participate, you don't participate. The government is not, going to throw you in jail, but they will say, well, we're not just going to give you a pass.
Okay. Thank you.
Yeah.
Nicole,
I'd be interested to know, was that an older
question?
I'm sorry.
No, go ahead.
This is Geneva. I just wanted to know, I was interested, was that provider older, been in medicine for a while, or not?
Yes. We have a lot, there's a lot of generations at work. So I believe the younger generation, they're sharing among the hospitals in Cleveland a lot more, so they see all of the different CEHRs a lot more than like our attendings do. And so the attendings are much more resistant because the system they know is only ours, and that's the only perspective that they're getting.
Yeah, so I see that a lot.
They struggle with
there's definitely a generational gap, and it does influence the way folks express themselves, but I don't necessarily think that the older folks feel so negatively about it. I think change is scary for a lot of people, and if you've been in medicine and you're a really good doctor, and now you have to go through a change that you might not be too good at, you might not want to be in front of your patients being seen as not fluent in this new technology. That's just my opinion.
Okay, I think we have time for one more question. I think Nicole had a question.
Okay. Nicole?
Maybe not.
Did you have a question?
Did you have a question? Did you raise your hand?
Sorry, there's also some people with questions in the chat.
Yes, I've noticed that.
Okay.
Oh, should I respond to those with me?
Oh, let's see. Yeah, if you want to, there's two of them. Donna McCauley has one, and Brian Toussaint has one also. Can you see those?
Okay. Yeah, let me. So is this Brian?
Brian's is the first one.
Yeah. So Brian's question is around physicians working more hours because of the technology, and they're rightfully frustrated, especially under RVU models. They do, however, want to provide quality care that comes with the technology. What is your organization or others doing to reward or support these doctors so that they are more willing to consistently use the system? So our organization provides a one-time bonus for meaningful use, and that has incentivized it for the providers. But we also provide a process that we're like, we know when you're training, when you're first getting up and operational, your productivity is going to go down. We're not going to count that against you, and as a matter of fact, we're telling you you need to book fewer appointments during that first 30 to 90 days, and we're not going to count that against you. So those are the two things that we're doing with our providers. And then we're also looking at their workflows, what's causing them to slow down in their productivity and then feel the need to have to stay longer hours. And we're finding some, they're forming some bad habits because they're still trying to avoid the technology. And so they still do paper charts, for example, and then at the end of the day, they put all of those into the electronic medical record. So they're causing themselves double work. So helping them kind of break out of that bad habit is another thing that we do. Okay, I'm going to move to Donna's question. So her first question is with the providers that went in 2011. As we move to stage 2 in our upgrade, are we seeing them having problems? As a system, because we also have hospitals, and hospitals have similar objectives, and as a medical group, we are all having problems making some adjustments to some of the newer objectives and the measures. How do we show that we are doing this? And so we are currently working that out. We're working through that, and it's literally a daily discussion. We go through each measure and we say, well, what's problematic for us? And how do we resolve this? So yes, I am seeing a lot of adjustments need to be made. And then Donna also wants to know, has anyone's organization switched their system? I spoke to CEO of a rural hospital, and she stated that they originally went Big Bang. That organization is now looking at upgrade and possibly a new system. I can say yes, because at the time, like in 2011, you don't look at things the way they will be in the future. And I know one of the big concerns for Summa Health System is we have multiple EHRs. We have one thing in one hospital, another EHR in another hospital. The ambulatory uses eClinicalWorks, like I said, and eClinicalWorks does not have an inpatient side of things. So when we're talking about interfacing and interoperability, it's a hot mess. We had a project that has not moved forward successfully called the Harmony Project, which its intent was to harmonize all these disparate systems and have them talking to each other, but it's just more than that project can handle. So yes, that is something that is happening. That is something that is being discussed. And then finally, do we have time for Brandon's question? Or
yeah, I think so. You got one. Actually, it's your time.
I see from the presentation that most of the meaningful use is going for hospitals and physician groups. Is anything like this for small doctors' offices? So, yes, there are 3 groups of eligible providers. There is the eligible professional, and that eligible professional can be in a single provider practice to, like our organization, 400 clinician medical group. And then the second eligible provider is an eligible hospital, and then the third eligible provider is a critical access hospital. What's out there to support like that small 1 to 3, 1 to 5 ambulatory practice are what's called regional extension centers. So they do outreach and support the small practices in their adopting of certified EHR technology and their meaningful use of EHR technology. Uh-oh, some more questions came in. Christine, do we have time for more?
Well, do you have time for more?
Oh,
it's
yeah.
Up to you.
Yeah.
Okay, if you've got time, go ahead and take it.
Okay, so Nicole B. asked, do you have any recommendations for physicians who are uninterested in training and learning the system. Also, do you feel the information system at your organization is fairly easy to use, or are the steps required to meet meaningful use very awkward? If so, are your providers using the system and meeting objectives despite the issues? So on the first part of the question, if providers are a part of a medical group such as Cinema Physicians, Inc., I won't say, we can twist arms, but becoming a meaningful user is a part of the contract. And so if they resist and they refuse to take the training and they refuse to even try to be meaningful users, there is a question of breach of contract. And then, they have to decide if they want to stay with the group or not. If you're talking about, that small practice, 1 or 2 providers in the practice, it's really, like I said before, it's not a mandate, and so it's a business decision. Do we want to move forward without ever adopting the technology and using it in a meaningful way, and what are the costs? So there are tremendous costs in implementing the technology, training, and upgrading and maintaining the technology compared to relatively small costs of Medicare payment adjustments, because Medicare is the only insurer that will adjust your payments in future years if you don't use the technology. Medicaid won't do it. And obviously the private insurers won't do it. So I have no real strong answer for how to get those who have made a business decision not to train and use the technology, to get them to use it. The only thing I can think of, if you're thinking about, driving the use of the technology from the provider's perspective, is, what kind of practice do you have, and do you often get new patients from other providers or transfer patients to other providers? And so you're dealing with nursing homes, rehab centers, and specialists, and you want to be able to communicate that summary of care record so that the patient doesn't have to start all over when they come to you or go to whoever you're referring them to. And then the second part of the question, every system that I've seen, so we don't just use eClinicalWorks. We have some practices that joined as a practice already on certified technology. And every system that I've seen has its quirks. It's not perfect, but we always have the grass is greener on the other side. So we do have those providers like, well, if only we were on this system, or if only we were on that system, things would be so much better. But then I talk to providers who are on this or that system, and they're like, well, we got an issue with this piece or an issue with that piece. So the thing that gets us through it is, again, like I said, just being driven. Like I need to get this data out, so I need to find a way to get it in and get it communicated to the CMS, as well as really, really, really strong vendor-client communication. Most vendors have a community of clients that get together either on blogs or, listservs and discuss their issues with the EMR, and then also, and I've done this myself, submit it request for development in the next version. You got to have this because this is ridiculous. So that's how we deal with any of the awkward features of our technology. Okay, so Kevin wants to know. Kevin's asking everyone, can you share your experience with dealing with multiple vendors and having multiple systems working together with maybe some legacy systems that might be in place? Kevin, if you have experience with it, it's probably the same experience that we all are having with it. And like I had stated before, you've got the issue of the lack of interoperability. And if you're in a large system, it's mind-numbing that a patient could be seen in the ER at your hospital, and then in the discharge note told to follow up with your primary care, but then you can't get that summary of care record over to the primary care, or vice versa. You know, the primary care is referring to rehab, but can't get the summary of care record over to the rehab facility because, you know, we're all using these different systems. And let's see. Okay, so is this the last question? Was that the last question, or is there more?
No, there's a couple more.
I was surprised to hear that CQMs are required to be sent electronically for EP. What kind of testing has been done so far? So starting back in 2012, the CMS let the community of participants know this was coming. And so starting in 2012, they had a pilot. So you could submit your CQMs electronically in the way that they're requiring us to do as of 2014. Because I'm the one that does the attestations for everybody, I was just like, I can't. I can't participate in the pilot. I'm just going to do it the way I've been doing it. So now we're just going to have to like do it live and cross our fingers that it works.
Okay, Geneva, I cannot thank you enough for what you have done today. I think the students are writing that it's been very eye-opening, and this is real-world stuff for them that they don't always get from those of us in the ivory tower. So it's sort of nice to know that it's nice to know that there's some real-life folks out there. To all the students that participated, these presentations, along with 3 others that we've done on the webinar, are archived, and I'll be sending out information about them on the listserv. So watch the listserv for it. All right. Thank you to everyone that has been on the call. I'm glad you were able to participate. And Geneva, thank you again. I thank you, and Nohim thanks you.
You are all welcome.
All right. Bye-bye, everyone.
Bye.